concluding remarks, na?
So concluding is for sure. Sir can
Super.
even start with the background of for GCT or something like that.
नहीं, but you are doing that, no?
I can, yes, sir.
Yeah. तो फिर वही रखते हैं, वैसे रखते हैं.
Okay, okay.
And
we are live.
Yeah, live. Okay, super.
So we'll start, sir.
Yes, absolutely.
Yes. So good morning, everybody, and I thank everybody to join for this pre-WIROC webinar, which is on giant cell tumors, which is part of the orthopedic oncology subspecialty. And I also thank my faculty to have given their valuable time on Sunday. And a special thanks to Dr. Manish Agarwal for willing to be the chairperson and be the guiding light for this webinar. The flow of events for the audience would be something that would help you in your general practice because giant cell tumors are a pretty common bone tumor that you would see in OPD practice. And every lytic lesion that you see, giant cell tumor is always going to be a differential diagnosis. So just to begin and give a little bit of brief about the faculty that we have Dr. Manish Agarwal as our chairperson, who is the premier orthopedic oncosurgeon in India. We have Dr. Prakash Nayak, who is a consultant orthopedic surgeon at Tata Memorial Hospital, who will also be our moderator and he will guide the proceedings for this webinar. We have Dr. Pratik Hegde, again from Tata Memorial Hospital, Dr. Manish Gundavda from Kokilaben Ambani Hospital, Dr. Chetan Anchan, again a prominent orthopedic oncosurgeon from Mumbai, Dr. Abhijit from Gujarat Cancer Society, who is also a very senior orthopedic oncosurgeon, and Dr. Rohan Gala, who is a spine surgeon but also does spine tumors, who will be helping us with some of his experiences with giant cell tumors in the spine. So we'll start with a little bit of introduction on giant cell tumor of the bone. Like I said, it is one of the commonest benign bone tumors that you see in practice. And this is usually seen in an adult mature skeleton. This is presenting with pain, sometimes swelling. And on evaluation and investigations, when you get an X-ray done, what you see is usually an expansile lytic lesion, which is eccentric, which causes, sort of a thinning of the cortex when it expands. And it is usually seen towards the joint, knee joint being the common, the distal femur and the proximal tibia. We also see it at the distal radius, which is again a very common site to see. A proximal humerus and a distal tibia, proximal fibula, these are sites which it can present to. Sometimes rare to see in practice, but it can present at any bone in the body, like we see in the spine as well. The pelvic bones, also what you call is the axial skeleton that we say. And important point and important from everybody's point of view is that giant cell tumors are going to come to you and you will have to at least be able to evaluate, if not manage it, maybe clinical evaluation, imaging, and then biopsy. And then either with the help of your orthopedic oncosurgery colleague or with your experience as an orthopedic surgeon, you can try to manage these tumors. So we have made this session in a way that you will be able to see some common presentations, some diagnostic dilemmas, and some uncommon ways of managing these tumors. Having said that it is the commonest tumor and also benign, the biggest challenge that we have is that it has a very high rate of recurrence. Because we can do intralesional surgery for these tumors, sometimes we end up getting local recurrences, which have to manage in a different way with a multi-prong approach. So I would like to pass this now to Dr. Chetan Anchan, who has an interesting case of a distal radius giant cell tumor. Sir, are you there?
Michelle, I don't see his name in the login details. So unless he's with you, he's here. Okay.
Yeah, I can see him, sir. I can see him. Yes,
yeah,
sir.
He's just joined. So just a couple of points as Dr. Chetananchan sets up his slides. And Michelle said something very valid, and we'll discuss that multiply as the cases go along. But the first thing that we look up when we see a focal lytic lesion, which is presenting in the distal radius or around the femur, and we think it is giant cell tumor, there are certain steps that we go through in the clinic before we are certain that it is giant cell tumor. And we'll discuss these points on every case. For starters, age is important. And anyone above the age of 40 or 45, we'll probably consider a myeloma lymphoma or rule that out, knowing that a primary giant cell tumor is commonly possible. And on the MR, the rule of thumb I like to use is T1 dark, T2 dark. It has to be dark on T1, it has to be dark on T2. And usually it will not be accompanied by a sclerotic limb because it's a predominantly lytic process. So once Dr. Chetan Anchan is ready with his slides, we'll discuss these points further on this case. Michelle, do you need to make him the host?
So they already made him the coach, but I think he's left and he's rejoining. So
Okay,
just
super.
a minute, sir.
Yeah, so
Yes.
so
Super.
one thing I want to point out is I think we've all gone through our postgraduate days being told that the commonest age for giant cell tumor is the 4th decade of life.
Yes.
And actually, the real situation today, at least in India, is that we see it much younger, 1 decade younger, or even a lot of our patients are even late teens and in their 20s. And I don't know why we are getting it much earlier than what it was in the West. But again, our theory has been that it is possibly related to our endemic deficiency of vitamin D that has probably got something to do with provoking the giant cell tumor to come. But I think this is something to remember in our differential diagnosis, that even if we see somebody in their 20s, when we often expect an osteosarcoma to be a common diagnosis, we have to remember that GCTs also occur, and we will need to do a biopsy sometimes to differentiate between the two, because osteosarcoma can be completely lytic, like the giant cell tumor. So this is something to keep in mind.
Yes. And the other fact that we generally always do in our clinic, like Dr. Agarwal said, first is to never assume it is the tumor that you see it is. And if you see a lytic process and you are suspecting GCT, first step is image it further. Once you've imaged it further and it fits your T1 dark, T2 dark pattern, the rule of thumb that I always follow is looking at the alkaline phosphatase. That's step 1. You look at your alkaline phosphatase and ensure that it is normal. That's very important because Brown's tumor, which occurs secondary to hyperparathyroidism, cannot be distinguished by the pathologist, often cannot be distinguished by the radiologist, and you have to prompt it clinically. And that's an important consideration, because if your alkaline phosphatase is elevated, you may or may not have hypocalcemia. You clearly know that you need to test for serum parathormone. If that is high, you do a UHG-NEC, identify the parathyroid gland, which is causing the hyperparathyroidism, send it to the head neck surgeons, and that will solve the problem. And oftentimes, a biopsy has been done where we have ignored the alk phos, which the pathologist may have called GCT. You've gone ahead and you've treated it, and then it recurs, or you have multiple other lesions. So just a rule of thumb, any GCT, look at alkaline phosphatase. Over.
I think Chetan is having some difficulty. Let's go over to the next person who can present.
Yes.
Their case.
So, Michelle, before Prateek takes over with his case, which has an overlay, I'll present 2 slides on something interesting, just taking forwards what we discussed, which is, how oftentimes you have a decision of GC and ABC come together, right? Yes. So oftentimes GCT and ABC come together. And we always think in our mind, well, is it GCT or an ABC? The pathologist always thinks, is it a GCT or an ABC? Now, the classic teaching that all of us have is an expantile eccentric lytic lesion. But the classic thing that we remember on the MRI is multiple fluid levels, right? The important thing for you to remember is you have to sit with your radiologist who would have done a contrast image, and you have to ensure that on no cross-sectional imaging, when you scroll through the entire extent of the lesion, you should not be seeing, I repeat, you should not be seeing any solid component. The moment you see a solid component, you know you are dealing with something called a secondary ABC, which means there is a primary tumor that could be a giant cell tumor or a chondroblastoma or many others in the list which have caused this ABC. And the reason why this is important is many a times in clinic, we have this error where we think it is an ABC, we ignore the solid component, and we inject a sclerosant under a tourniquet and get out and hope that it heals. It's important, again, alkaline phosphatase, calcium phosphate, and absence of solid component, right? This is a common confusion between GCT and ABC. I'll stop here, a few key points, and probably Pratik can take over.
Again, I'm going to emphasize that you should not inject a sclerosant till you have
Absolutely.
a histological diagnosis of ABC.
Absolutely.
And when we say solid component, I think it has to be a solid enhancing component. Because when there is a bleed within an ABC without contrast, it is very difficult to tell whether that dark area is solid or liquid or a blood product. So I think it is very important to get a contrast scan if you have any difficulty in diagnosing between ABC, GCT, or a brown tumor. A contrast is absolutely necessary.
And a rule of thumb clue to a very important point that MGA raised is that, typically when you prescribe an MR, unless it's done by a center that routinely does tumor imaging, routine tumor imaging centers will send you a basic T1, a basic T2, a post-contrast image. Many centers, because they're used to dealing with trauma and ligament injuries where a PD sequence is important, will just give you stir and PD sequences where the tumor lights up, send it to you. Those are inferior modalities, inferior images to really look for what you want to see. So if you suspect a tumor, it is important that your radiologist knows you're suspecting a tumor and will give you intrinsic T1, T2, and post-contrast images, and not only focus on PD and stir. Over.
Prakash, I am back.
Perfect. If you can share your slides, go for it.
Sorry, my computer audio was not connecting, so yeah. So can you see my presentation? Yeah.
Yes, sir.
Yes, we can.
Okay. Yeah. So this is a 20-year-old male who came to me with complaints of pain around the left wrist since 2 months. His X-ray showed a lytic lesion in the distal end of radius. So that is what the X-ray shows. Should we discuss the X-ray, or should I run through the presentation?
Any key points that you want to make which will help people in practice, go for it.
Yeah. Is there any interaction?
Not live, no.
Okay.
I mean, amongst us, but from the audience, they'll send it on
Right.
the YouTube link.
So I think, Prakash, can you just briefly read this X-ray for the...
Sure. So what I'm looking at is, first, I'm looking at an adult individual where the physis are fused. I'm looking at a distal radius lesion, a fairly well demarcated lesion, a predominantly lytic process on the anteroposterior view. I'm also not seeing a very sclerotic limb, but I'm seeing a sharp zone of transition. If I'm looking at the lateral X-ray, I also see that it has broken through the anterior volar cortex. I'm seeing some soft tissue component. I'm not seeing any obvious matrix. Neither am I seeing any obvious malignant periosteal reaction. So all of this makes me think I'm probably looking at a benign aggressive lesion. And at this site and in this adulthood, I would probably suspect a giant cell tumor to start with. Yeah. Over.
So the typical X-ray that you would expect to see in a GCT or bone. So the next investigation that we would always want to do is MRI. Now, MRI gives us additional information than what the X-ray is giving. X-ray gives us an idea about what is the possible diagnosis. What MRI gives us is the anatomical information about the true extent of this disease. Now, if you look at the lateral view, you can appreciate that there's a huge soft tissue mass which you couldn't really, we could suspect on the X-ray, but you really couldn't really, make out. So this is what this MRI is for. So it is not a tool for diagnosis of GCT, but it is for understanding the anatomical extent of the disease. So imaging findings are suggestive of GCT of bone. Then what next? Biopsy is most important. The other thing that we have to do in all GCT of bone, wherever you suspect, is to rule out metabolic bone disease. Okay? In all suspected cases of GCT of bone, basic investigation: serum calcium, serum alkaline phosphatase, and serum phosphorus levels. Serum calcium levels will be high, and serum alkaline level phosphatase levels will be high in case of metabolic bone disease. In this case, the biopsy was GCT of bone. Now, another thing to clarify is this term that you may sometimes come across in your report. The pathologist, instead of saying GCT of bone, may say it is giant cell containing tumor of bone or giant cell rich tumor of bone. That is a very dangerous, statement. So never assume a giant cell containing tumor of bone or a giant cell rich tumor of bone is GCT of bone. That is a descriptive term. GCT of bone is a very specific diagnosis. So whenever you have this kind of reporting of giant cell containing or giant cell rich tumor of bone, you should speak to your pathologist and figure out what exactly does he mean by that, because there are a lot of other conditions where you can have giant cell, in the tumor, including osteosarcoma. Okay. Now, in this case, the biopsy was GCT of bone. Of course, this is a very old case. At that time, this histone marker was not available, but now this new H3.3 G34W is a histone marker which is very, very specific for diagnosis of GCT of bones. So nowadays, we can be more confident about the reporting of the pathology, specifically if they have done this particular marker study. So what to do now? Curettage or resection? Now, in this particular case, it was very tempting to curate this particular case because the articular surface looked good. Overall, 3 out of these 4 sides of this bone looked intact. Of course, on MRI, it had a large soft tissue mass on the volar side. So I decided to go ahead with curettage and bone grafting. The alternative is we can also use bone cement to fill this cavity. I have used auto iliacrest bone graft. We can also use allograft if it is available. In this particular case, I did a curettage and bone grafting. So this is his post-op X-ray. This is his 3 months post-op X-ray. He had excellent function, and the graft appeared to be healing well, and there were no other issues. He came to me 1 year later, and he was very comfortable, had good function. X-ray looked quite satisfying. The bone graft looked incorporated in this patient. 15 months post-op, he came to me with complaints of some pain and swelling in the wrist region. Now here we are clearly seeing something going on. There is a lytic lesion or region here in the radioulnar joint region, and we can more clearly see a soft tissue mass on the, or a soft tissue swelling on the volar side. So that was his clinical picture. Clearly something is going wrong here. So what do you do? MRI, certainly, because that would give me a better picture of what is going on. And he had a huge soft tissue recurrence. Not just soft tissue, there was disease in the bone also, but with a large soft tissue mass. So what do you do now? One question, Prakash, will you answer that? Do you
Yes.
need to biopsy him again? Now this is, a year later.
Yeah. So typically, if it's an obvious recurrence where there was no doubt, then you may avoid a biopsy. If it's a doubtful recurrence beyond 2 or 3 years, then it's safe to do a biopsy. But I would say this, that a biopsy never harms. It always helps. And it keeps your mind clear, the patient's mind clear. And the rule of thumb is always to biopsy. The decision to not biopsy is something that's taken very carefully considered, but the rule of thumb is to biopsy.
Yeah. So not to
Now,
biopsy is a very considered.
I'm just going to intervene here
Yes,
now.
sir.
2% of what is diagnosed at GCT can turn out to be malignant GCTs, and we've seen some of these. The quality of pathology reporting is not standard through our country, and it varies from pathologist to pathologist. So especially if the review pathology has been done outside somewhere where you don't know whether the pathologist who has reported has experience with musculoskeletal tumors, I think when you're seeing a recurrence, as a rule, you should biopsy it. And the second thing which I wanted to stress is that that marker is not reliable for GCT. The problem is it comes positive even in malignant GCT. And we've seen a couple of cases very recently where the marker was positive and it was assumed that it will be a GCT, whereas all along it was actually a malignant giant cell tumor on that. So this is something to remember and keep in the back of the mind, that wherever you're using an immunohistochemistry marker, it has to be correlated with your clinical picture as well as your radiological picture, can't be seen in isolation. And second thing is that when you get a recurrence, particularly if it comes very quickly or if it has come very late or anything odd about the recurrence, I think it is much better to biopsy it than to just assume that this is giant cell tumor.
I think that those are very, very wise words, sir. I mean, considering, the challenges that we face in the diagnosis and treatment of this particular condition. In this particular case, I didn't repeat the biopsy because the pathologist was very reliable and everything, fit with this particular case of, to suspect this is a clear recurrence of a benign GCT. But definitely where we have concerns, biopsy never harmed anybody. But
And a
it
big
should
difference.
be a needle.
Yeah.
What is that?
And a big difference, Chetan, with your case is you had done the primary surgery.
Yes.
The entire specimen was with your pathologist. Correct. Who you rely on. Correct. Which is a big difference than it being operated in the community where you don't know where it was reported and then coming to you as a recurrence. Big difference.
Yeah, if it had come from elsewhere to me, I would definitely do a repeat biopsy and then proceed with the treatment. So what to do now, recurettage or resection? Well, that is just for the sake of asking. Clearly here, recurettage is out of question. So I had to go ahead with the resection. Now, when it comes to resection of lower end of radius, there are a lot of reconstruction options. Typically, the major alternative is between joint preserving procedure called fibula arthroplasty or wrist fusion using various bone graft options like fibula electus bone graft or the same side ulna. Ulna, again, you can use it in two ways, either centralize the ulna, or what we typically do is distal ulnar translation or shifting the ulnar graft to the side of the radius and then doing a wrist fusion. I have no experience with fibula arthroplasty, and we have got excellent results with the distal ulnar translation. But depending on the gap that you see, you can also use iliac crest bone graft, or if you choose, you can use fibula as bone graft. So what we did is a wrist fusion with distal ulnar translation. Those are pictures of the surgical specimen and the fixation. This is the post-op X-ray. So what we have done is we have taken a segment of the ulna and shifted it to fill this defect in the radius after the resection and fused it with a long plate. So this is 2 years post-op X-ray. Now this is almost 15 years in surgery. He's doing really well. Those are his photographs on follow-up. So the advantage of this ulnar translation is it retains the pronosupination movement, which is very, very useful for optimal functioning of the hand. So they don't really miss on losing the wrist movements unless that is very, very required for their particular, profession. So those are his function videos. So it can supinate and pronate completely. So to summarize, unlike in other common locations for GCT of bone, incidence of local recurrence after intralesional curettage procedures in the lower end of radius is significantly high. Revision surgery around the wrist is very challenging due to many important structures traversing a very tight space. I really struggled with this particular resection because I had gone volar during my first surgery also. So going again there with all the vascular, neural and muscular tendinous structures there was quite challenging. So decision regarding the kind of surgical management of GCT of lower end of radius has to be taken very carefully. That is choosing between curettage and resection. They have compared the functional result of wrist arthrodesis versus arthroplasty with proximal fibula graft following wide excision of the distal radius in this particular paper. And what they have clearly found that arthrodesis of the reconstructed radiocarpal joint provided better function than fibula arthroplasty. Thank you. We can discuss any interesting points related to this particular case.
Yeah, so that's wonderful. So while the BOS team relays us any questions, if I were to summarize, one giant cell tumor of the distal radius is common. We must biopsy, rule out metabolic bone disease or primary hyperparathyroidism. We have to take the decision of curettage very carefully because the recurrence rates in the distal radius are high because of its challenging location with very important anatomical structures close by. But even if it does recur, we must remember recurrence does not make giant cell tumor a malignant tumor. It will remain benign, and despite that recur, as was excellently shown by Dr. Anjan in his case, where a successful resection and ulnar translation gave excellent function. And lastly, I want Dr. Agarwal to come in here and tell us about how Dr. Anjan said the function is retained based on what they want to do, and how one of his patients, who is a nationally renowned sculptor who had this similar disease, who went on to do something pretty phenomenal after his ulnar translocation. So I don't know if MGA is prepared with a picture of his sculpture at short notice, but even if he doesn't, it's a great story.
But it's not about the picture. I think everybody who lives in Bombay must have seen the Dabbawala statue. So that will give them an idea. Or if they have gone to the Palladium Mall, they have seen that life-size truck and the workers in Mumbai on the ground floor. So that is the guy we are talking about. It's not about what you're going to do. It's about, I think the most important thing that I have learned from my patients is that you need to ask them whether they are prepared for a recurrence. And we realize that personalities are different, and some people can accept a recurrence and go for another surgery with the aim of preserving the wrist. Whereas there are others who are completely shattered with the idea of another surgery. Even though the tumor is benign, I think it disrupts their work and it disrupts their finances very often. So I think this discussion has to be done upfront with the patient in a site like the distal radius, where we know recurrences are common. As far as the function is concerned, I think numerous articles have shown that pronation, supination is probably the more important of the movements that are required at the wrist compared to, say, just a flexion or extension, which can be compensated for very easily by the fingers and the shoulders. So I think as long as you can preserve the pronosupination, I think you get good function. And we've now started radializing the translocated ulna in order to, again, avoid that narrowing of the wrist, which was a common objection to doing an ulnar translocation. So once you shifted more towards the scaphoid, and now what we are doing is also not fusing the metacarpal, but just the proximal carpal row with a distal radius plate. So that also reduces or limits the amount of fusion that you are getting at the wrist. And these are things that can make maybe a fusion more acceptable. But recently at Insight, at Calicut, we were talking to Domenico Campanacci, who does a lot of osteoarticular allografts for the distal radius. And in their experience, this is a procedure which helps preserve the wrist, gives the stability, and still gives excellent function. So this is something which we have to keep in mind, that the treatment will keep evolving let's not be rigid about what can be done. And I think depending on what options are available to you, you have to discuss with the patient and then offer it to the patient. This is what you're going to do. It's very important to decide upfront, even before the biopsy, because as you have seen in Chetan's case, the mass was volar. And if you're going to resect it, you generally go dorsoradial or dorsal. And therefore, the biopsy has to be planned correctly. If you're going to curate this, you probably will prefer to go volar. And that's the reason why the surgeon who's going to do the surgery must actually mark on the wrist what is going to be his line of incision, particularly if you're going to send that biopsy to the radiologist to go ahead and do it, so that they have an idea of what is your plan and you will not disrupt any anatomical barriers for your surgery in future. So I think the take-home message from this case is that every time you see a case, you have to customize it to the patient's requirement, get a correct diagnosis, and then offer the best that you can do. One last thing is that you have to follow these patients up. And Chetan, I think, will be able to show from the X-ray that if you look at the serial X-rays, you could have picked up the recurrence earlier. The moment you see a lytic area which wasn't there on the previous X-ray, I think that's high degree of suspicion for a recurrence, particularly at the site like the distal radius. And the earlier you pick it up, then the chance is that you may be able to curate it and get away with it rather than having to do a big resection. So these are the messages that I get from this case.
Wonderful.
Yeah, we
Yes.
can see it in
This one probably had a lytic focus there.
Yeah, there is a lytic focus and there is a small soft tissue bulge here. This was 3 months, before he came with this.
And I think a good clinical pointer that we use is pain. A lot of patients come back with pain before they have a soft tissue component. And the recurrence of that pain is a big bulb that tells us that we are probably dealing with a recurrence. Great. That was a wonderful case. And without further ado, we will then take this theme of the confusion of GCT, ABC, the fluid levels that we saw, and how do we deal with that in practice. And we'll have Dr. Pratik Hegde lead us through that case. Over to you, Pratik.
Thank you, sir.
Sorry, sir. Yes, sir. I just want to say that the questions from the audience is one, bone graft versus bone cement, which we'll be addressing later. So I just want the audience to be hanging around.
Yes, perfect.
Well, if they have anything particular related to the distal radius, maybe this is the time we can take it. Otherwise, what is general, like we said, between bone grafting cement, we can deal with it later.
Yes, sir. So the other question was about fibular arthroplasty versus ulnar translocation.
I think Chetan already answered
that.
Yes,
that is why. So that is already been discussed. The literature is discussed, so that question is answered.
But generally, the practice is that orthopedic surgeons prefer to do a fibula arthroplasty, and that is the preferred mode of reconstruction. And that is why I think that question has come up, because when we were in our postgraduate training also, if there's a distal radius resection to be done, the option that used to pop up is always a fibula arthroplasty.
And so anybody, I would say, is that anybody who has seen the outcomes of the ulnar translocation and wrist arthrodesis has actually not done anything else. And this is, I mean, it's about training, it's about what you've seen. All through medical colleges, I think the standard teaching has been fibular arthroplasty, and I think that has to change. And that has been again another very message from the case, that we need to look at the proper option rather than just because you have not seen something else or you haven't heard of anything else. I think you have to look for something which is a better option. And literature has clearly shown that a fibular arthroplasty has a high chance of subluxation and bad outcome. And this is something which I think is not new. I think there are at least 10 papers I have seen over the last 15 years or so. And I think the only arthroplasty of the fibula which seems to work, as I said, is the allograft, osteoarticular allograft, done by somebody who's an expert and where the availability is good. And I don't think in India we still have that situation. So I think it's not an option for us.
Even that allograft is a distal radius allograft, not a fibula.
Correct.
Graft.
Correct.
It doesn't match, the articular, although on X-ray it looks a bit similar, but there is no match of the articular surface.
And I think the point is
Absolutely.
immediate post-op, it looks good, feels good.
On an X-ray.
The X-ray and the effect that is seen, the subluxation and the wrist pain starts a few months down the line, and which is not observed. And even in the cases of allograft, I think what they do is they preserve the capsule so that they can get that capsular tension and capsular repair done, which might not be the case with a fibular arthroplasty.
Correct.
And we have to remember that when you take bone from another donor site like the fibula, you have to repair the collateral ligament back.
Yeah.
And there is a risk to the common peroneal nerve. And all of us have seen laxity in the knee as well as foot drops, which have happened when the fibular arthroplasties have been done. And this is in addition to the bad wrist function that we see. So I think where there is an option of something better and something local, I think that is something which it's a very strong message that we want to give, is that why add any risk of further morbidity for a patient when you can do something better from the bone which is locally available.
Yeah.
Along with a poorer functional outcome.
Yeah.
So there are a lot of benefits this procedure offers. Only one important thing to look at is to fix the rotation very correctly. Otherwise, your range may change.
Well, let me put it this way, that ulnar translocation is not an easy orthopedic operation.
Yeah.
It requires a little bit of understanding, and maybe you have to see a few cases before you can do it well. So this is probably the barrier to a widespread adoption of this method.
Yeah. So I would then now proceed to the next case.
Yes, yes.
This was a case which had come to me a few years back before I joined Tata Hospital. And this was a 17-year-old girl with a swelling over the foot. And she showed it to a local orthopedic surgeon who got an X-ray done. And this was the X-ray at presentation. So you can see the first metatarsal is involved at the base. It's got expansile lesion lytic, ballooning of the cortex is seen. No periosteal reaction. There's a sharp margin, sharp cutoff, looked benign on the X-ray. But only on the basis of the X-ray, the orthopedic surgeon said this looks like an aneurysmal bone cyst. The location fits, the age fits. So he went ahead and did a sclerotherapy for this, and assuming that it would heal that. But unfortunately, it did not, and it ballooned up 3 months down the line. And at this point, once that initial sclerotherapy did not work, that is when he decided to get an MRI done. And this was the MRI. Now, on this MRI, we can see that this is the T1 image. It's completely black. But what is important is that this part where it is articulated, it's sharp. And this is the distal articular surface where you can still see some part of the bone still available for us. Now, this was the axial view. The entire bone was ballooned with the flexor tendons distally on the plantar aspect also getting pushed by the lesion. Now, this was the view that was causing confusion to the orthopedic surgeon, because he said there are a lot of fluid levels seen. And he was still again convinced that it could be an aneurysmal bone cyst, and was planning on a second dose of sclerotherapy. And this is when the patient presented to me. So the radiological pictures somehow didn't match with an aneurysmal bone cyst. But these were the options that were being considered. Sclerotherapy again, curate it, resect that entire thing, or do a re-amputation, assuming it is malignant. Now, all these options that are mentioned are based on assumptions of one histology or the other. A sclerosant based on the assumption that it's a ABC, curettage based on the assumption that it's a benign disease, and a ray amp based on the assumption that it's a malignant disease. So rather than working on assumptions, it's better to get a biopsy done. And that was done, a needle biopsy, no need of an open biopsy, where a small stab incision itself is enough and you get good material. The biopsy report confirmed it to be a giant cell tumor. So now then we go back, if the histology is confirmed, then what are the options in front of us? Sclerotherapy is out. Considering the images, I would say a ray amp is also out. Since it's a benign disease, we can give a chance at salvage. Now the question is between curettage and and a resection, and is there a role of denosumab in this? Now, because there is hardly any cortical bone left for us to resect, for us to curate it against, even if after giving denosumab, what denosumab does is basically just forms a bony shell. It will still not give us the margin which is required for curettage. So the options which were left were resection of that gap of metatarsal. So once we decided that a resection is the option, the options for reconstruction were either a fibula from the same patient, same leg as an autograft or an allograft, or should we go ahead with a non-biological nail cement spacer? So the patient was counseled and they were willing to go ahead with a fibula autograft. This was some intra-op photos where, because if you can see, there was an overhang of this soft tissue component, which was overlapping the medial cuneiform, because of which even the medial cuneiform had to be sacrificed. And this was the fibula graft that was harvested. And these are the intra-op pictures where the fibula autograft was fixed proximally and distally with small metatarsal plates. And this is the immediate post-op X-ray and an X-ray 6 months down the line. So the message from this case that I saw, that not to assume your histology, which is what Dr. Prakash Naik also alluded to. You should always have a histopathological diagnosis, and then you can discuss about the management with the patient. Yeah, thank you.
Lovely. So wonderful messages. The first error was there was no cross-sectional imaging done, right,
Yeah.
Pratik?
Yeah.
And there was an assumption, which was the first error. The second error was the follow-up was done at around 4 months, you said, when the patient
Yes.
presented with a big mass. So the
Yeah.
second error was the patient was not kept on a close follow-up. And so these are the classic errors which one must avoid. One must never treat a lytic lesion without a proper MRI or without a proper biopsy. I want to ask the others, we can spend about 5 minutes more on discussing this case, on would you have chosen to treat this differently without going into too many details of the use of denosumab, which I think we'll cover later, perhaps even in a separate webinar. We'll stick to the basics of deciding on curettage versus resection and what's going through our minds when one is deciding, can I curate this or not? Dr. Chetan or Michelle or MGA?
Well, let me put it that I would do this in a little different way, is that I would preserve the metatarsophalangeal joint here. So I would use denosumab to marginate the tumor. And even if that proximal, the distal margin, if it is contaminated and I need to curate out some of the tumor to preserve that distal part of the metatarsal, I would do that.
Yeah.
I would do that because I think the joint, the first metatarsophalangeal joint, has very important function in the foot. So that is what I would have done differently, given denosumab maybe just 2 doses, 15 days apart. Get the tumor to solidify so that we don't get spillage. Because again, we have seen that in the small bones of the hand and feet, the recurrence rates are very common because the tumor spills when you try to resect it. So denosumab helps in solidifying it and getting the whole thing out. Even if it doesn't form a shell of bone, that's fine, as long as you get the whole tumor out. So the difference would be only that I would have used the fibula itself, but preserved the distal metatarsal.
Good point.
And if one were unable to save the distal metatarsal head, or if one were unable to save the metatarsophalangeal joint, then is our preference to fuse that joint, considering it's an important first ray, or would some of us prefer to do a reamp?
Yeah, so the challenge that I have found is that you have to get that alignment perfect, because otherwise you will end up with callosities, or you will get hyperextension at that toe and the toe doesn't contract and you get footwear use problems. So normally, if I have something like that, I would probably involve now a foot specialist in. We are coming to an era where we have this expertise available.
Yeah.
And I think it's a good idea to involve them with the reconstruction. I don't think a prosthetic arthroplasty still is evolved to an extent at which it is reliable and it is tempting for us to use it. So I would still use a fusion, but I think I would do it with the foot surgeon so that I get my angles perfectly correct on the case.
That's excellent advice. So the message for all of us is always seek expert help, whether it's an expert pathologist, radiologist, a surgeon who resects the tumor, and an expert who can help you with the reconstruction. And that's how an excellent team would help give the best outcomes to the patient. One last point that I'd like to make, and this is a feedback that we had from a lot of our orthopedic colleagues, is that in the past and even during residency, all hand and foot, there's this concept which many of our colleagues carry, where you think it's a solid ABC. It's a solid ABC. In the foot and in the hand, a solid ABC is common. We must remember now the WHO has taken away that term solid ABC, because all of them are and should be treated like giant cell tumors. So they are as aggressive locally. We must take all the care to diagnose them preoperatively, a very careful decision on curating or resecting them, and not neglect them as a lesser cousin of giant cell tumor just because they're arising in the hands or in the feet, which was probably one big error, like Prateek pointed out in this case. Wonderful. Michelle, do you want to have any questions from the audience before we move on to our next case?
There are no questions for this talk as of now. If they come up, we'll definitely take care of it during the course.
Yeah.
Wonderful, wonderful. So, Michelle, you can probably invite the next speaker and figure out how the flow is.
So, just before I invite our next speaker, Dr. Abhijit, I would just want the audience to know that many a times these giant cell tumors have been asymptomatic for a couple of months in individuals who are healthy and can have a high tolerance for pain. They get this diagnosis made only after they've had a trivial trauma with a pathological fracture. So a pathological fracture through a lytic lesion is a dilemma that many orthopedic surgeons feel. Some may miss it because a fracture fragment also looks similar to a lytic lesion, but careful investigation, X-ray, MRI, and then biopsy, and then planning the treatment is again what we want to advocate to the audience. So Dr. Abhijit, welcome and thank you for sharing this
Good morning.
case.
So can you see my screen?
Yes, Abhijit,
Yes,
we can.
Yeah, good morning. So thanks for considering me to be a part of this program. So my topic is pathological fracture in giant cell tumor. Greetings from GCRI, Ahmedabad. So there is a high fight going in Maharashtra. So fracture versus no fracture. So which is a fracture group and which is no fracture group, we don't know. And in giant cell tumor, incidence is around 20%, we can say. So we published one of our papers in 2015 in JBJ's British to analyze whether pathological fracture affects the local recurrence rate. So the incidence was around 18%, and the conclusion was ultimately that it doesn't preclude whether we should go always for resection and curettage can be performed. So second, we published one of our papers in 2017, and it should be always a two treatment options. One is curettage and resection, and choose your treatment very logically, tailor-made approach. And we go to few cases. So here there is a case of 21 years gentleman with pathological fracture of distal and femur. Like Agarwal sir said that the incidence in Indian scenario is bit earlier as compared to classical Western world. And we have significant number of cases in our 20s and 30s. So this is a case where 21 years gentleman with distal and femur pathological fracture. The patient presented with this fracture to us. So the treatment options here, what can be? So either we have two options, one resection, second can be curettage. And we can add some medical line of management which can help in either of the two. So in this case, we gave zoledronic acid to this patient. So 4 milligram IV zoledronic acid. After all renal workup, dental workup, supplementation with calcium, vitamin D, it responded well. We gave a knee brace to the patient. Then we gave second and third injection. The lesion again healed very properly. We can appreciate there is a posterior lesion which can be seen here, posteriorly near the condylar region. We gave fourth injection. We did MRI. All workups were done, and we thought that curettage can be done in this case. So extended curettage was done for this case, and because it was a fracture, we supplemented it with a plate. So extended curettage, filling the cavity with bone cement. What we do commonly, we use bone grafts in very less cases. Preferred choice of treatment for us is bone cement, and this was his first X-ray, curettage, and a plate was fixed. This was his 3 years plus follow-up. So example of pathological fracture femur treated with zoledronic acid, curettage, and cementing. We go to next case, 26 years female, again pathological fracture of femur after diagnosis of giant cell tumor. This was her X-ray, and again two options here again available. You can do curettage or resection. We go to third case, which is by Dr. Vinod Naneria from Indore. So Dr. Naneria sir is a senior orthopedic surgeon having significant experience in giant cell tumors for last 30-35 years. So this was his case, and proximal tibia, giant cell tumor. So he does more of upfront curettage. Our philosophy is give first zoledronic acid or denosumab and then curettage. His philosophy is you can give these drugs after curettage. So this was his case where curettage was done. He fixed with a plate and bone cement. This was immediate follow-up in 2018. Plate, curate, and cement. This was 1 year follow-up in 2019. This was a functional outcome in 2019, so nearly 1 year plus follow-up. This was his follow-up at 4 years. So can curettage be done in proximal tibia with giant cell tumor pathological fracture? Yes. It can have good outcomes. Resection could have been an option, but preserving patient's own knee is always a good thing for benign tumors like giant cell tumor. We go to next case, which was one of our case, 27 years female, pathological fracture again of tibia following giant cell tumor diagnosis. This was her intra-op images. Curettage was done. This was how we assess the cavity. So in extended curettage, we use burr, we use high-speed burr, we use pulse lavage. In few cases, we use argon beam laser, hydrogen peroxide as one of the adjuvant, and bone cement to fill the cavity. In this case, we only filled with bone cement. Next case, every case you can't salvage the joint. So it's a 47 years gentleman with a giant cell tumor with pathological fracture, and patient was diabetic in this case. So the first X-ray, we can see fracture is there, and this is what the patient presented to us. He is a gentleman from Punjab. So we gave him again zoledronic acid. So we have tried both the drugs, zoledronic and denosumab, both having equal outcomes. Zoledronic acid, we need to give 2 or 3 injections. It will take a bit more time, but cost-effective option for a government hospital. So again, here we can see posteriorly soft tissue mass is there. Fracture is healing well. This was his MRI. And this is the time where we intervene. for the surgery. So in this case, resection of distal femur, curettage was not done, and resection of distal femur and megaprosthesis was placed for this patient. Lastly, we go to a case of distal tibia. Again, quite common site, pathological fracture of distal tibia and fibula also we can see here. So this is his MRI. And in this case, we resected the distal tibia. We have options of resection and fusing the ankle, like Chetan sir said. In his radius case, we have option of both mobile joint and immobile joint. In distal tibia, we commonly fuse the ankle joint. So this was his resected specimen. On the cut specimen, we can see the fibula is fractured, tibia is fractured, and this was his cavity. So in this case, we did place 2 fibula studs and a plate. So we have seen these examples, and again, what we can conclude, pathological fracture, it's quite common. You need to immobilize the patient. So it can be at 2 presentations. Either the patient presents to you with a fracture, or during the treatment course, when he has come to your hospital during biopsy or your medical line of management, he may get fracture. So immobilize the patient if it's around the knee joint. That will be a good suggestion. And both treatment options are good, curettage versus resection, but it should be always an individualized approach. So thank you very much.
Thank you, Abhijit, for that wide variety of cases and a very difficult and a controversial topic. The first message we all must remember is a pathologic fracture is best prevented. If it cannot be prevented, then it is to be taken seriously. As Abhijit alluded to, and I'll have questions for the entire panel, it is very important to know where the pathologic fracture has occurred, because generally around the knee, the fracture is either in the metaphysis or on the articular surface. And that matters in a big way to the eventual function that the patient might have. General, Abhijit would agree, and all of us would agree, the world has moved where we are clearly going to curate a lesion. Most teams would shun away from any denosumab because denosumab just makes your curettage very hard. Your recurrence rates go higher because it forms bone in places you don't want it to form bone, and it's very difficult to then get your margins in a clear fashion. So if you have clearly decided curettage is the way to go, it's best maybe to avoid any denosumab. But when there is a pathologic fracture, particularly in the joint, above the joint, there's always a question, should I give preoperative zoledronic acid and or denosumab to let the fracture heal and then consider salvage versus resection? Or if there is a small displaced fracture, which I can fix now, should I jump in upfront, curate, fix? Because once there is a displaced fracture, which is malunited with zoledronic acid or denosumab, it's very hard to correct that deformity. So that's the challenge that we are facing here. But importantly, a pathologic fracture does not make the GCT high grade. You still is the same GCT that you would get when there is no fracture. And hence we need to determine each case based on its merits. So I'd first like Dr. Agarwal maybe to comment on what is his philosophy today on dealing with a pathologic fracture, intra-articular versus metaphyseal in the distal femur.
Yeah, so Prakash, I think you were absolutely correct in saying that we must first identify where is that fracture, because if it is an intra-articular fracture, you need early surgery. You can't wait. You're not going to wait for any denosumab or bisphosphonates, because if you are preserving the joint, you want that alignment as good as you can get. So what I look at from a surgeon point of view is whether I can fix this whole thing in reasonable anatomical configuration. It may not be perfectly anatomical, but if you can get reasonable anatomical configuration in the non-articular area and good articular congruity, then I think this joint has a very good chance of being saved, and the recurrence rates actually are not something you need to worry about if you do a good curettage. Now, I'm a little apprehensive about using cement directly where there is no subchondral bone, because I've seen too many people with problems where the cement has got exposed in the joint and you don't realize it immediately. It comes a few years later. It's something which is very difficult to salvage once that happens. So I think on the articular side, where there is no subchondral bone at all, where you are getting ping pong cartilage, I think it is a good idea to put some bone there. If you're planning to restore the joint, then that will help you in the long run. How you fix it is an individual surgeon's decision. There are many ways to do a particular surgery or to put things back. Some people like 2 plates, some people like 1 plate, some people just like would put K-wires and fix it. I think it all depends on what is your experience and what is the geometry of the fracture. But the principle is that you must preserve the joint wherever it is possible to put the anatomy back, because a natural joint is clearly better, as Abhijit said, as compared to a prosthetic joint. And this is something, principle on which we follow. Even very large tumors with bad fractures, we've seen can be put back.
Excellent points. And I think Abhijit and MGA and even Pratik before made very important points that cost and availability is an important constraint for a lot of our patients. And we all agree that in a young patient with good bone stock, long life ahead, use bone wherever we can use bone because they have a long functional life ahead of them. However, having said that, sometimes it's a challenge for you to get allograft if you need it. Patients may refuse consent for an autograft. And I think Abhijit, for a lot of his cases, was pointing or alluding to that fact that if you don't have access to either, and if you're put in a tight spot, cement may be a way to go. But when you have very little subchondral bone, we have to fight for getting bone as far as possible because that's going to give the best long-term function for a lot of these young patients. We will not right now go into the debate of zoledronic acid, which, as Abhijit said, is cheaper. It's available for 3,000 or 4,000 or 15-minute IV injection versus denosumab short course, as Dr. Agarwal mentioned, for some cases, which are given in 2 doses for about 16,000, 17,000 per dose with a subcutaneous injection at day 0 and at day 14. We'll probably go into that discussion later, but just something to think about, that if you need to use it, you will use what's more reliable and what's affordable. This is a great segue now into our next case. Now, before that,
before we go, since we are talking about fractures,
yes,
I mean, it would be an important point also to make that when we talk about 360-degree visualization and we're talking of intra-articular fractures, it's also really important to know the extent of joint contamination and actually see that contamination, wash it out. You see the seeding into the synovium. I mean, it would be really important if you're looking at intra-articular fractures, that joint now becomes a part of the cavity and that would need clearance if you're doing any salvage.
Absolutely, absolutely. So that was Manit Gundavda, who's our
one point I want to add. We are doing follow-up MRIs now. 3 years, 5 years, 10 years line the line. So 10, 12 years follow-up MRI, both the knee, if possible, single knee, the disease knee, and try to get how the cartilage is getting deformed. So long-term follow-ups with only cement. So that data we are just trying to collect. So in future we can show that it doesn't damage that much cartilage. So because very limited access we have for allografts at present. So very tough to get allograft, and bone cement 10 to 15 years follow up with MRIs to prove the case that only cement still it can work. There is a bit radiological osteoarthritis, we can say, but still the patient's own joint is saved. That is ultimate purpose for it.
Right. And Michelle, I think you had put up a question where the ideal timing of surgery with intra-articular fracture, I think we have answered that with our discussion, where if you want to save the joint, fix it, you go in as soon as possible, not have any malunion. Great. I think this is a great segue. I think, Michelle, our next talk is going to be on sandwich reconstruction versus bone only versus bone with cement. And I'll get you to introduce our next speaker.
Hello. Yeah, sorry
Yes,
for
Rishi,
the
go ahead.
delay. No, basically there was one more question that was coming from the YouTube channel, and that also is going to be discussed in the next talk as well. That which to choose, denosumab, no denosumab, zoledronic acid, which is better, which to be chosen. We have already discussed part of it now, and now we will, when we discuss about denosumab in detail, that questions also will be answered. So now we'll have Dr. Manit with us, who is going to talk about the various, cement versus no cement, bone graft versus cement, sandwich technique, what is better, what is chosen when, and what is in the best interest of the patient. Over to you, Dr. Manit. Thank you.
Hi, so the slides are visible.
Yes.
Yes, man.
So thank you once again. Very interesting Sunday morning session that we're having. And we've all seen multiple cases, multiple limb salvage options. I think we've all narrowed down that where possible, the joint needs to be saved. And like we discussed, we are seeing younger patients, we are seeing healthy joints, and we're all now inclined towards doing a very good extended curettage. We have all the adjuvants, we are using chemical thermal agents, but after a very good curettage, what happens is we make a defect a bigger defect. And then the surgeon is left with a cavity, which is varying in volume, varying in tumors, varying in size based on the tumor. But despite all of that, we see that most of these cavities are contained because you have the opposite cortex, which is generally intact, uh, as opposed to the side in which you're making the big door or the window through which you're doing the curettage. So the biggest discussion, the challenge that always comes is on the side of the joint, where the cartilage is exposed, the subchondral bone is preserved, not preserved, and all of the discussion in literature, all of the discussion, most of which we've had here, is always, limited to saving the joint because you're doing joint salvage surgery over here. Now, obviously, the choice of options are limited. We have bone, we have cement, or we have something which is a combination of the two, which is sandwich reconstruction. So just a simple single slide pros and cons discussion. Obviously, bone has the advantage. It is a biological material. You're restoring the bone stock. It will remodel once it's incorporated, once it's healed. However, like we discussed, autografts are limited in quantity. Iliac crest or fibula are the general preferred choices of autografts that are routinely harvested for reconstruction. And obviously, donor site morbidity is a serious concern because of the quantity of autograft that we desire when the cavity is big. In India, allografts are not as easily available. Processing, infection risk, delayed healing, all of those add to the allograft complications. And the also important factor is the delay in healing. So when you put in a big cavity reconstructed only with bone graft, the patient is on protected weight bearing. You're waiting for the fracture to heal. You're waiting for the bone graft to get incorporated. The cavity needs significant stability. There is temporary stability through the fixation that we achieve, but the bone graft will take its own time to get incorporated. On the opposite side, we have cement, which is readily available in any quantity that we want. It conforms to an irregular defect. The GCT cavities are irregular. They are along the joints. They are long, metaphyseal. So you can contour the cement in any irregular defect that is there. The big benefit is immediate strength on compression. Cement is really poor in torsional or rotational loading, but compression is good. So we can allow weight bearing if the cementation is done well and it fills the entire cavity. And the biggest advantage that literature has described about using cement is it acts as an extra adjuvant. The heat that is released during polymerization has been described by multiple papers as an additional adjuvant, which not only aids in the reconstruction, but probably some papers claim that it has decreased recurrence risk. Obviously, this is only observational data and there is no direct causal correlation. But if it works, then there's one more adjuvant that you don't really need to worry about. You need to reconstruct the cavity anyways. And if cement is giving you that adjuvant as well as reconstruction options, it's really good. As the orthopedic oncologist who will keep seeing our patients on follow-up, we are always looking at recurrences. Now, bone versus cement. Cement is radio opaque. It is easy to spot a radiolucent lytic area around the cement, which was previously not there, as opposed to filling the entire cavity with bone, which may sometimes lyse. You may have a reaction. You may have a bone incorporation with a temporary period of lysis, which then gets formed into new bone. And all of those can always be misinterpreted at recurrences. Patients may end up undergoing further investigations that scare, that scanxiety, as we call it, of recurrence, no recurrence, which on the cement side is relatively easier because it's solid, radio opaque, and any changes suspect recurrence unless proven otherwise. And coming to the main question that we have concerns over is whether cement or bone near the joint. So there has been a lot of discussion on this in the past 10-15 years. And the real question is, does cement really affect the articular cartilage? And as Dr. Abhijit Salunke just said, that he is doing the study, and we're very excited already, all of us, to see what the outcomes are, to have Indian data about, bilateral knee comparisons and see what the outcomes are, whether we can answer this question, whether cement under the joint is bad or good or doesn't make a difference at all. But Lackman et al. In 2015, they had 63 cases, and they did not show any case of accelerated cartilage wear on follow-up of almost 5 years. What they were able to study was subchondral stiffness. So they said that if the subchondral bone was reconstructed with bone graft, which was allo or autograft, the subchondral stiffness was returned to normal in 12 weeks. But the recovery when it was used with cement was only up to 80%. So it never went back to 100%, the stiffness of the subchondral bone. So that probably in the long run for young patients may make a difference in accelerated osteoarthritis. But again, it's all observational data. Again, in 2007, this MRI-based study was published by the Netherlands group, and they did gadolinium-enhanced MRIs. They also did biochemical serum markers. They used COMP, the cartilage oligometric matrix proteins, to look at arthritis and degeneration. And again, they could not correlate radiological or biochemical degeneration, whether cement was used or bone graft was used. And all of these are small studies. All of these don't change practice today. But as any orthopedic surgeon, it's very very early in our training, we've taught that biological reconstruction, subchondral bone, all of that is giving the nutrition to the cartilage. And therefore, it makes sense to have what is called a combination. And that is what we advocate. It's like if you have a subchondral bone which is deficient in more than 25% of the articular cartilage, if you have a ping pong cartilage, as Dr. Agarwal said, if there is any suspicion, then we do something called a sandwich reconstruction, which is basically a layering technique. You have subchondral reconstruction with bone graft, which can be a limited quantity of autograft, which is a combination of morselized and chips of autograft, which can be harvested from the iliac crest. And the rest of the cavity, because we don't have a lot of quantity for autograft, the rest of the cavity can provide mechanical stability, and we can use bone cement. And all of this, in addition, the discussion comes whether is this stable enough and do we need a fixation. So as a general rule of thumb, if 50% or more of the AP and the lateral is involved, fixation is recommended to provide that additional stability till the entire construct stabilizes and is good enough for the patient to perform all routine functional activities. So we just see a small video to recuperate what we've just discussed. So it's always a patient customized approach. And like we discussed, more than 25% of the articular surface, if it's undermined, subchondral bone grafting before cementing, which is the sandwich reconstruction procedure, is what is recommended. C-arm can be used to confirm that you filled the subchondral bone with adequate cavity, the heat of the polymerization is not affecting the cartilage directly. And this is a barrier of the inner table of iliac crest, which is acting as the barrier. The original sandwich reconstruction described the use of gel foam, but you can use bone. This is an important point of keeping the tourniquet on because you want the heat of the cement polymerization to act as an adjuvant. If the tourniquet is deflated, the heat sink effect does not act as well. And again, like we discussed, the 90% of the cavity is filled with cement, so you still get that radio opaque cavity assessment for recurrence. This is the study which did the gadolinium enhanced MRIs, and they were not able to show biochemical or radiological osteoarthritis after using either cement or bone graft. So Ward and Lee also proposed this approach of subchondral thickness assessment, and 25% of the exposed bone graft, ping pong cartilage, all of those are what we use as rough guides during our surgery to decide on sandwich reconstruction. The autograft requirement becomes small. Another important point is the autograft needs to be harvested with a clean, separate, sterile trolley to prevent cross-contamination. This is the representation of a sandwich. And plating, as we discussed, if the cross-section exceeds 50% of the bone in the AP or the lateral views, this is the final outcome. You see the subchondral bone, you see the fixation, and majority of the cavity filled with cement. So it gives you the best of both worlds if you have a sandwich reconstruction. Thank you.
Excellent. Thank you, Manit. That was a great video and a great summary of the entire debate around the best option that we have when there is a ping pong cartilage, where we always worry if we just have bone, is it going to collapse? Is it going to accelerate osteoarthritis? And on the other hand, we worry if there is cement beneath the subchondral bone, would we have accelerated wear? And you did mention that there have been enough long-term studies to not conclusively show that it happens. On the other hand, we've also had many cases of in our own universe and across the world where cement has become bare through the cartilage, right? Where there was very little subchondral bone, cement was used just beneath the cartilage, or with very little subchondral bone and the cement was bare. And as Dr. Agarwal mentioned, it's a challenging situation where you have bare cement and an arthroscopy surgeon has seen cement in the joint. It's a very difficult challenge to convert that into a salvageable knee. So it's not a solved problem yet. We will need much longer follow-up to know what happens to them. And the other big challenge, which we see being discussed amongst all of us and the arthroplasty surgeons, is knee osteoarthritis is so common, is so prevalent. And God forbid, when one of these GCT survivors ends up needing a conventional knee replacement, what do they do then when there's a big blob of cement lying beneath, underlying the cartilage? So these are the challenges that we are looking at, and which is why we all think of how best to get bone. If we can't get bone, how best to preserve the subchondral joint. And you also made an excellent point where I noticed you showed that the biomechanical studies have shown that your pull-out strength is better when you put screws once the cement has set, right? A lot of us choose to do differently. You put in the plate first, then keep some area, then pack in the cement. And there's another group that would fill in the cement, let the cement harden, and then put in the plate. And there was always this debate, which is better. The first seems easier. The latter, drilling through set cement, seems harder. But like you showed, the biomechanical studies have shown in the lab, at least, that the pull-out strength is much better when you have drilled screws through an already set cement. So these were some of the broad debates. And now I want to invite, remember, Dr. Chetan Anshan also mentioned these debates, these concerns about using cement versus bone. So I want just a quick poll from Dr. Anshan, Dr. MGA, and Bishil and Abhijit. how do you think about your sandwich reconstruction today? Do you use an allograft? Do you use iliac crest autograft? And do you let the cement set, then put a plate? Do you put a plate first, then put cement?
Before we take these opinions, I think putting the screws after the cement set, more than biomechanicals, has been more an experience-based thing, because we always need to remember that recurrences may occur. And then when you put in the screws before the cement has set, that screw is practically never coming out. So it's always you have to think of the next if it need be. But obviously it's good that the biomechanical is the studies are on our side. It makes it easy to enforce that put in the screws after the cement has set.
So I think you're on mute.
So we recently actually went through tons of literature, articles, in fact, everything on this topic of whether we actually get arthritis after cementing a giant cell tumor close to the articular cartilage. So there has been a recent review. This is an effort open review published just a few months ago. And very clearly it has shown that 30% of patients have actually demonstrated some changes of osteoarthritis, though none of these patients actually were clinically symptomatic. So though you may see radiological arthritis, we don't know what happens in the long run. And the challenge of doing arthroplasty with the underlying blob of cement is going to remain. Now that remains even with a sandwich reconstruction. So that's not going away. We also understand is that there is a big difference between just the thickness of the subchondral bone and the area of the subchondral bone which has been involved by the tumor. And both of these things are important and they work together. So just 1 millimeter of subchondral bone remaining, but not a big area of the cartilage, may be compatible with just cementing. Now, if the rule of thumb is that if you are able to indent that subchondral bone, or that cartilage is ping pong like we were discussing, then I think it's a good idea to put bone. But if you've got reasonable stiffness, then maybe it may not matter much. Now, again, talking of lab studies, very clearly the laboratory study, which there's a study which has shown what is the heat transmission and damage to the articular cartilage with the various thicknesses of the subchondral bone remaining. And the recommendation from that study is that you must have 3 millimeters of subchondral bone to prevent any heat-related damage to the articular cartilage. But that is a cadaveric study and an in vitro study. So we don't know how much is the repair capability of the cartilage as well from the nutrition which happens. And in real life, probably the damage is not as bad as it is made out to be. So I think depending on the situation, every surgeon has to decide what will be the best way of reconstructing it. Fortunately, in this era, you are now getting bone graft substitutes which are giving you some rigidity as well. Like the calcium phosphate cements can give you some amount of rigidity to support your articular cartilage before you put in that cement and get hold of that screw. So according to me, that is something which can be used, or maybe that combined with a little bit of bone is something which will be enough to take care of the cartilage concerns that one has in GCT, particularly when you are dealing with fracture, as we have seen, where you don't want cement actually extruding through the fracture lines or going intra-articular through those boundaries. So I think if we can share that monogram, the GCT monogram which BOS is coming out with the members of the BOS, I think everybody will get what is the status today, and then they can use their own judgment as to how they would like to reconstruct the defect in their case. Some reconstruction is necessary, is what I can say. Don't leave that cavity unsupported, because particularly around the knee, I think the stresses around are so high that your cavity has a high chance of collapsing. So unless your volume of the tumor cavity is less than 30 cc, is what is calculated around the knee, it may not be safe to leave that cavity unsupported.
Yeah, absolutely. Great points. And yes, it's probably a wise idea to leave no big cavity unsupported. And as Dr. Agarwal mentioned, Dr. Gautam Zaveri and colleagues have led this effort on having a GCT monograph this year as a part of BOS academic activity, which my colleagues Dr. Puri and Manish Tuti have edited. All of us have contributed on various aspects for surgeons from across India. And that monograph would soon be released in public, freely available to all members. And that shall be coming soon, which will effectively summarize the state of the current evidence, individual practice notes, and tips on how to deal with various aspects of a giant cell tumor of bone. And we all look forward to that. The one question that I had both to Abhijit and perhaps to Dr. Chetananjan is, or in fact, any of us have they ever had an experience where they've actually had to go back, take down cement, put back bone for some problem, whether it's a road traffic accident with a fracture around the cement, an elderly individual who now needs a knee replacement, or any other situation where the cement there was just bad, that had to come out and be replaced by bone?
I had a patient who had been operated for GCT of the lower end of femur, cementing done, I think almost 10 years ago. He had a road traffic accident and he had a fracture in the supracondylar region, and it was just impossible for me to really put it back because of the mantle of cement, and there was arthritis in the knee. So he ended up with a mega processor. There was no other way to put it back. But yes, given a choice, I would want to fix it back, and I don't think fixing through cement is impossible. But here his joint was also already damaged. So it was, at some point he would need a revision. Probably this was an excuse for that.
Well, important
And
considerations.
there have been situations where in a cemented patient, there has been local recurrence of disease. Now, those are difficult cases, especially where you feel that you can again save the joint. You can do a recurettage. So after cementing, if you have a local recurrence of disease, that is a very, very difficult situation, especially where you want to save the joint again, because then you have to remove that entire mantle of old cement. It won't do just to do a limited curettage, because most of these times the disease will creep into all those spaces between the articular surface and the cement. So if you just do a local curettage and expect that it will go away, I think that is a risky choice. So here you have to remove that entire mantle of old cement, and removing that is really a very, very difficult job. In fact, you have to break it like a stone mason. You have to make multiple drill holes and use a chisel. In fact, I autoclaved a mason's chisel from a sutar's shop because the osteotome would just break or go blunt. So I have used that, and that cement chips keep flying all over the place. You have to in fact use protection, otherwise you may get these things hit your face or go into your eyes. So it's a real difficult job, and you may end up fracturing the condyle. There could be intra-articular fracture at that time. So I think whenever you're doing something like that, you probably have to keep a mega processor standby just in case you end up, destroying the bone.
Those are such.
Yeah.
Mishi,
It's really tough to remove cement. You need to make it in small pieces. Just start with small, then remove some chunk and it flies in the OT. And to remove the plate, again, very tough job. So you should be mentally prepared that the plate will not come out. Your cement will come out, but the plate upper screws are, if they are locked, welded, it will not come out. So that you should be mentally prepared. again cure it and pack again with cement, what sir said, if possible.
But
Or you
then
want to, then you need to take the cut above the plate. That is again a problem. The screws are not coming. So you use a longer plate, you need to resect it longer. So in recurrent cement with plate, it is genuinely a tough case.
So the message clearly is you have to be prepared for a recurrence. As Dr. Chetananchan correctly mentioned, even picking up recurrence on the MRI all around the cement is a challenge when you have metal artifacts. Oftentimes we wish that there's nothing bad beyond the cement. All the recurrence is on this side, and let's leave the cement alone. And that's a big error, as both Dr. Abhijit and Dr. Chetan have said. And it is a procedure which tests your patience to the limit. You have to remain exceptionally patient. As divide and rule, break them into small pieces. It's a hard job. And we've all learned Dr. Chetananchan say how he's actually gone back and gotten a mason's chisel. We all use our own tricks. You destroy drills, you destroy osteotomes, or you use osteotomes that you've already destroyed from the past. Come up with loads of patience and try and save that bone. Hope the bone doesn't crack beyond the cement. But important that you deal every bit of the margin very seriously, because this may be your last chance to not have a recurrence. Because as Dr. Chetananchan said, it's an important end goal where if you destroy the bone or if you get recurrence after a recurettage with very little cartilage, you're looking at a possible megaprosthesis. And you want to avoid that for your young patients. So the big message is take your recurrences seriously, plan them well, image them well, go with all the armamentarium that you need and all the patience that you need. I think, Manit, did you have a point to make?
No, I'm good. Thanks.
So I'm going to say a few things,
yes,
Prakash. Now, having been in this field for a long time, you have no choice but to deal with the problems that you have created in the past and to learn from it. So we've all managed that cement, and I can tell you, fortunately, that I have not had to do a megaprosthesis because of a cement. The 5mm osteotome is a brilliant tool to create cracks within that cement. Now, unlike popular perception, we may think that a bigger osteotome is better, but it is the 5mm osteotome which actually is the best at creating these cracks and allowing you to break that cement into smaller blocks. Now, we have also seen that cement does not stick to the bone. So once you have cracked it up and you are able to remove it, then you can again re-cement that back. And I also want to share, there were 2 patients last year who required a knee replacement. One was a GCT with a fracture, which I had done when I was in Tata Memorial in 2003. And he came for a knee replacement. And there's another patient who had surgery about 18 years ago and in the proximal tibia with just cementing done elsewhere and required a knee replacement. Now, there was a big contrast. The one which had bone reconstruction, the arthroplasty surgeon did not even call me. It was so straightforward to go ahead and do arthroplasty there. But in the proximal tibia, I had to be present on the case. I had to drill through that cement, create the channel so that the stemmed implant could go in, and once again cement around that part. So that is a little tricky, but it is possible. Now, this is something which I think all of us are going to get more and more experience of as the number of arthroplasties increase in these patients who've been previously treated for GCT. And that arthritis is, as I said, not necessarily from the treatment of GCT, but that can be a natural degenerative process which is happening. But when you cement your GCTs, always keep in mind that you are likely to be called upon to deal with that blob of cement that you are putting in. And as soon as you have that in mind, I think you will be a little more careful of how you are cementing it and have a plan about how you're going to deal with it if required to when you have to go down again into that cement.
Oh, absolutely, absolutely. Great points. And like you said, sir, the other big challenge that I have been a part of where we have had to revise is that the knee surgeons oftentimes are forced to use wedges or tantalum cones to rebuild the defects if a long stem is not suitable. But the point is, it makes it very complex. It's again multidisciplinary, where you need the tumor surgeon who created the problem in the first place to help the knee surgeon solve some of it to optimize results. So cement's never easy. Bone is always easy, but the bone always is not available and not always possible, right? So we got to deal with what we have. Michelle, were there any further questions before we jump on to something very complex and a completely different ball game of actual giant cell tumor with many questions, many concerns? We'll probably tackle all questions that we have about extremity GCT.
Yes, sir. So no more questions on this.
So one more point I'm going to make.
Yes.
It's a common question asked is, do I need to remove that cement and reconstruct with bone once, say, 3 years have passed and I know there is no recurrence? And I have always wondered why this concept started. I think it was that fear, like we were discussing, is what's going to happen with all that cement under the articular surface.
Yeah.
We recently had one patient who actually was a Bangladeshi patient who had gone over to Australia, got his giant cell tumor surgery done. They had cementing in the proximal tibia. 3 years later, when there was no recurrence, he was called back to Australia and they removed that cement and put bone graft.
Wooden bone.
Now, everything was okay till a year and a half later, this guy again started having pain, severe pain. And when we came back, there was clearly something abnormal going on in that bone. We thought it's infection because his CRP, ASR was high, it was very painful. He wasn't able to go back to Australia, so he came to us and we biopsied it. And it was a malignancy in a previously treated giant cell tumor. Now, that's why I said it can come at any stage. This was just a year and a half after his previous surgery, where apparently there was no tumor at all. And then this has come back like this. And often we are asked this question is, do I need to go back and tell the patient you're going to need a second surgery like we tell them for implant removal? And the answer is no. I don't think you need to go back. I think you have to deal with the cement when it creates a problem, rather than creating a problem by dealing with it in every case. There could be lots of problems, as we've discussed. You could fracture the bone, you could damage the cartilage, and that's not something you want to get into.
True. And a lot of patients may never require a resurgery. And some who do will deal with the problem if and when they do.
Yes.
Because committing to a surgery in every patient is exposing them to complications of anesthesia, surgery, infection. And like you said, most patients may escape that problem. Wonderful. So now we'll move to a completely different ballgame. And we thought it is important to touch upon axial GCT. More importantly, we will not discuss pelvis or sacral GCT, which are operable or not operable, but importantly, vertebral GCT. Why vertebral GCT? Because many of the patients will present with significant pain, symptoms of instability, or the occasional patient may present with neurodeficit. Now, remember, you are in a situation where you don't often have a diagnosis. The neurodeficit is impending. And then you are in the question put forth to you, should I operate this immediately? And it's a very vascular tumor. And we know when we want to cure it, particularly around the vertebra, we will always consider embolizing it pre-op to reduce the vascularity and get a better field for disease control. On the other hand, we now also have denosumab. And we know that the denosumab can give you a good boundary around the lesion. Would that boundary really help the spine surgeon resect it or block as far as possible, curate the remainder, minimize blood loss, immediately reduce pain, and improve outcomes? And all this is a very tricky, difficult situation where, again, you need a teamwork of the pathologist, the spine surgeon, the interventional radiologist, and the tumor group. And to discuss some of these issues, and following which we can have a short discussion on pre-operative denosumab, yes, no, right? As a segue into our discussion. We'll invite Dr. Rohan Gala, who has collaborated with quite a few of our cases at TMH. He and Dr. Dhar, both for vertebral GCTs and other vertebral tumors that we deal with, both for block excisions, partial resection curettage, stabilization post-curettage. So I'd like to call upon him. Michelle and I would both like to call upon him. And the case that he's likely to discuss was something that had a lot of back and forth between our team and his on what the correct flow of treatment is. And here I'll want all of the panelists to put their minds after he has presented the case on if they would have treated this any differently. Over to you, Rohan.
Yes, sir. So I thank you for inviting me for this excellent session. And before I start my main case, I just want to spark some controversy of what is going to follow as far as denosumab is concerned. So this is just a 36-year-old lady who had come with restrictions of neck movement in all directions. The pain was more on the right side. We just did a transoral biopsy as we do, like for any tissue diagnosis, and it came out to be GCT. Now, given the kind of anatomical location that this tumor is, it was very difficult for us to plan on such a young lady with 2 children, whether to go as grotesque as possible or should we get away without something like much smaller. So we started by giving her denosumab. So we started with 120 milligram monthly doses, and that is what happened to her at 6 months. This after was when she was immobilized in a halo, and then she was put on denosumab for 6 months. She improved clinically, and that's her at 40 months. So we continued denosumab at tapering doses, and at 40 months, this is her picture without we touching her at all. The function is okay, as you can see that there is enough flexion extension movements with her. And then we had stopped this, and this is her today at 6 years from the time we started her on denosumab. So this is one of our very few 3 to 4 cases that we have of standalone denosumab therapy, where the patient has not come back with a recurrence. And this is, she's still doing fine. So the answer whether denosumab works differently in axial spine as compared to appendicular skeleton is still, I would be more pro denosumab than being anti when it comes to the axial skeleton. And now coming back to our case, so this is her at, again, 6 years. From a completely lytic lesion to the entire bone being filled up with, a good margins at the C1, C2 joint bilaterally. So this was a patient who was a 26-year-old male who came with gait unsteadiness since 3 months, and now he has difficulty in walking. So this is all he had, and he had gone to some other surgeon. So this is exactly what he had presented. Because he had difficulty in walking, I think the neurology was somewhere around 3, where he was still like a non-walker, but he could walk with support. So this is how he had presented. At this point in time, I would ask the expert panel, how would you go about? Would you still go in saying that, okay, this neurology is 3/5, or would you still prefer a tissue diagnosis given his age? Any one of you all can take this.
Yes. So if I were to kickstart, so it's a good question, right? 26, very likely this is going to be a primary tumor arising in the vertebra. And what I'm thinking is 2 ends. One, that I've ruled out metabolic causes. Then I'm thinking, is it a benign GCT, or would it be a sarcoma? Let's consider the worst case scenario. Even if this were a sarcoma, am I going to be able to get an oblong resection here with good margins around the dura? And my answer is no. So in this particular case, if a patient is presenting with a critical neuro deficit, globally, getting them preoperative embolization, decompressing the spine, and getting a tissue diagnosis is not a bad problem, except, and here is a big exception, if you're dealing with a round cell tumor, right? And a round cell tumor will completely change the paradigm of what we are dealing with, which is why if you are in a situation like at TMH, if this patient comes with a critical neurodeficit, he will get immediate biopsy under CT guidance. We would get an immediate frozen section. And the only question to the pathologist would be, is this a round cell tumor? If it is a round cell tumor, you will escape surgery and chemo and radiation will work wonders. And if they tell us, no, it's not a round cell tumor, it is something else, then we at least have clarity on how to proceed with further. Any thoughts from MGA?
Yeah, so one more point to consider in addition to round cell tumor is there instability which is going to require fixation. Now,
Absolutely.
if there is instability, like for example here, or there is a retropulsed bony fragment which is not going to go away with chemotherapy, then you will need surgical decompression.
Correct.
In which case, then surgery becomes a straight
mandatory
option on that, even for a round cell tumor on that. So that's the only difference. But wherever there is expert pathologist with frozen section facility, I think it is worthwhile knowing the diagnosis before you go in. And in any case, when you're going in, say, without any prior treatment with denosumab or whatever it is a good idea to do an angio and embolize if you're going in at that time, because it is not going to do you any harm. It is only going to give you benefit. It improves the visualization, and you will at least end up clearing the space around the dura so that the patient can recover the deficit.
Yes, sir. So very rightly put, that, even if it's a neurology, which is 3+, I would still have a tissue diagnosis in hand rather than going all in and, being very, aggressively decompressing this lesion and then realizing it's another creature altogether. Sir, any role of PET CT at this point in time, or just tissue diagnosis would suffice?
So if I think if I don't know what is the diagnosis, I do get a PET CT done. That is simply because you want to know whether you're dealing with, how aggressive you need to be with the lesion. And like you said, once I know the histology, even from a frozen section, I can decide whether this is something which is likely to require a bigger decompression where I don't have anything else. For example, in an RCC, I know that we don't have, the radiation doesn't work very well, but we'll be using only systemic therapy. So how much to decompress, how much of the vertebral body you're going to deal with, or how much of the soft tissue mass you're going to care for will again depend on what is the pathology of that.
Yes, sir. So,
and Rohan, just to add one perspective to this, like how we would deal with in our hospital, age would be very important for us, right?
Absolutely.
So young patient, very likely this may be a primary. And as Dr. Agarwal said, if this were a 45-year-old gentleman, then it depends on if it's a critical acute neurodeficit that has come that day, or is it a gradually evolving one. In a critical deficit, because the FDG PET CT takes preparation, availability, fasting, etc. Our strategy for a critical neurodeficit is a quick CT tap, right? Where it tells us if there is any obvious primary. And we had a case which you know of very well just 2 days ago, where a 48-year-old lady who came with an acute deficit, a quick CT tap showed that she had a very big lung mass, multiple liver mets, multiple vertebral mets. We already know what the diagnosis is, and we can plan accordingly, right? So just to keep that the acuteness of the deficit and age in mind.
Absolutely spot on, sir, because it also depends on how static the deficit has been over what time, rather than it going into an acute deficit. So as this case was managed outside, so the surgeon just got a PET CT done directly without any tissue diagnosis. And given the fact that this gentleman was 3/5, he went in. And this is what he's done. He just went in with a PET CT, and so his symptoms improved after a week, and he was walking independently. So the biopsy done here showed an epithelial appearance and clear cells, and some osteoclast-like giant cells. Now, one more very important point I want to highlight for the general orthopedicians here is, where do you send your biopsy? This is of utmost importance, as you had correctly said, that if you send it to a place which usually does routinely clears out, and, assesses all these tumors, it is of paramount importance rather than this going to a local lab, because then what it will do is just cloud your diagnosis eventually. So this is what had happened. So 3 weeks later, he again develops unsteadiness in gait, and he ambulates with support now again. The surgeon again did a PET CT. Now the PET CT shows slightly expansile lesion now, which is increasing over time. So then they review the histopathological diagnosis. It still comes out to be a malignant epithelioid differentiate. Now, whatever multidisciplinary approach they must have had, he undergoes radiotherapy. He takes around a 30-day cycle for around 10 days, from Jan 2020 to Feb 2020. Again, he has relief, but after 2 weeks, again, he deteriorates, and now he's unable to stand without support. So now they go for a repeat diagnosis. Like they want to do the histopathology, the biopsy again. And this is the first time where now the biopsy is done elsewhere, and now they are coming up with like features of GCT with ABC-like areas in March 2020. So he was operated back in the end of 2019, had recovered twice, has given a cycle of radiotherapy, and now he undergoes repeat tissue diagnosis only for the pathologist to realize that now there are features of GCT with ABC-like areas. So again, they were not clear. He undergoes a repeat biopsy in April. And this is what it comes out to be. Now they are coming up with more stronger evidence of a giant cell tumor because it was rich in osteoclast. 4 months now, for 4 months, he is out for follow-up because then we had the pandemic coming in. So he was just lost to follow-up. And then he presents to us in August 2020, completely bedridden. And this is the MRI of him in August 2020. Now he had COVID. And believe you me, we were planning to operate on him during those times where always the pulmonary function was deteriorating. And his previous surgical scar was present. He had radiation at that level, but the gross power was 1/5 in both lower limbs, and he was spastic. So this is how he had presented to us. So that was the time where I know that this patient was operated. There was so much of dilemma as far as the diagnosis is concerned, because initially the diagnosis was done elsewhere till they referred her to a tertiary center, and then too, they did the biopsy twice just to be absolutely sure as to what this is. So now he comes to us with a proven 2-time proven giant cell tumor. And this is how it presented to us. So as usual, you know the protocol that we did a preoperative embolization. So that was the time when I had called Dr. Michel alongside, and we just did a simple separation surgery, first to relieve his neurology, which was there since 3 months. And now again, post that, the diagnosis yet again came to be GCT. So this is the second surgery he's undergone. And now he started improving because after the separation that we had to do, which was around a 180-degree separation of the tumor, which was engulfing, we put him on denosumab. So this is the largest study of the axial skeleton denosumab, where it has been concluded that denosumab is an effective treatment for patients in giant cell tumors of the bone from spine to the sacrum. So now this was a randomized trial by the UCLA group, and they had 132 patients where they have either pre-treated them, they have had standalone therapies, or they have given them post-operatively to prevent recurrences. Now, this is another very important article that we had by the famous oncologist from Rizzoli, Dr. Palmerini, who has said that the current role of neoadjuvant denosumab, especially when a pathological fracture occurs, can be tried for 2 to 6 months. But in the long run, when to stop it, how much to give it is still controversial. So that's what we did. We gave him 120 milligram of denosumab a month. So from September 2020, you can see that the tumor is shrinking. Now, if you see the Feb 2021 MRI, you can see the restoration of the CSF flow in the image to your right. And because of the financial constraints that we had, we never put him on denosumab for more than 8 months. We had scheduled it in such a way that we give him 6 doses initially, and then we spaced out the 2 remaining doses at 3 months interval. So you can see here also that the MRI showing the ovoid cord is now become circular. That is because of the separation surgery that occurred from posterior, as well as the mild shrinkage of the tumor that occurred anteriorly thanks to denosumab. Now, this is the CT scan of the same patient after 6 doses. And then when we spaced out the second, one more dose at 8 months, you see the sclerotic rim being formed, as we all know that how it's delineating the entire tumor. This was a very important paper given by Boriani, where he has actually classified that how does denosumab act. And this is a CT-based classification that once denosumab acts on the actual tumors, this is how it should respond. And then he had classified them into these 3 types. That what is the type at which, at what point of denosumab when you're giving. So we all had given this patient denosumab for 6 months, and we had to classify as to where this patient stands now. And based on that, we can plan the further management. So this is him. We did not give any further denosumab. This is him at 1 year of follow-up, where now for being completely bedridden for 4 months, he's now walking with walker. This is, again, we have not put him on anything. We are just observing him from 2022 to 2023. That's a 3-year follow-up. And you see how it's remodeling, and there is no evidence of recurrence till now. We've also had the MRI later on. And that's him walking independently with no evidence of any recurrence and just clinical improvement over time. So this is the September 2020 MRI that he had come to us with. And this is the February 2023 MRI, almost 2.5 years later, where we don't see anything that has happened only with 8 doses of denosumab. There are also enough evidence, there's also enough evidence, and literature also supports that recurrence. Once you are treating a record GCT and then treating it with denosumab, the chances of recurrences become lower and lower over time. So this is what his picture is in Feb 2023. And that's him. And this is Feb 2023. You see how the entire canal is being remodeled all the time with denosumab. So not only is the tumor shrinking, but the tumor is also kind of, forming better outlines thanks to treatment of denosumab, and then just giving supportive therapy with vitamin D and calcium. That's all we've done. So this is him at Feb 2023. That's September 2023. So almost 3 years follow-up. And just recently, we got his CT scan also done. But again, I'm just showing you the comparison of the same tumor which behaved so badly in September 2020. Now is shrinking by Feb 2023. And that is September 2023. You see how the tumor is remodeling with this, with no supportive denosumab therapy. The 8 doses that we had given were the only 8 doses that he has received. And that's him riding a bike. So someone who's bedridden for 4 months has now recovered fully in about 3.5 years. So again, this puts in a lot of controversy as to what happened, because GCT with denosumab, a record GCT with only 8 doses of denosumab and no signs of evidence radiologically or clinically, with only clinical improvement. Again, we should ask ourselves this question as to how much is too much. And what is the end point of this? And that's him again from 2022 to 2023 and 2024. This is the CT scan of the same patient with the recent one, which is September 2024. So again, I don't know, but the take home should be that preferably the tissue diagnosis should have been sent to a tertiary center. This tumor should have been originally managed in an algorithmic way. So maybe, tissue diagnosis of paramount importance here. Denosumab, as far as I go as a spine surgeon, can be used preoperatively and even postoperatively to prevent recurrence. And with regards to dosage, there are still mixed opinions on the amount, the duration, and the strategy. I'm open to questions. So the current strategy is 6 months follow-up, which is clinical and radiological, and we may consider resection if at all the disease recurrence takes place. So this is like a 4-year follow-up for this patient now. Thank you.
That's a great case, Rohan. Thank you for sharing that with us. And you raised many, many important points. And as you rightly said, also controversial points. First is you summarize it well. If there is a critical neurodeficit, you get immediate tissue diagnosis, get frozen. And if surgery is imminent, we proceed with surgery with embolization. If it's a gradual neurodeficit, you get diagnosis, stage the patient well, then decide what you need to do. When you said about denosumab, you rightly said that in the axial skeleton, first, it can help you get stability, reduce pain, and also possibly achieve tumor shrinkage, right? Whether that helps you get outcomes better with surgery, if the patient is regardless going to need surgery, is a question that we haven't answered yet. More importantly, if you do use preoperative denosumab in the occasional case, you may be able to avoid embolization in that individual. And that is sometimes important, particularly in the dorsal spine, because you may have a tumor that is being fed by the arteria magna, which also supplies the spinal cord. And oftentimes, in 2 out of 10 cases, in big tumors around the dorsal spine, we get a call from interventional radiology and they tell us, well, listen, there's a big risk of paraplegia. We cannot embolize this as well as we would like to. And super selective embolization will work, but maybe only 50% of your tumor will get devascularized. So that is, again, a situation where denosumab may come to our rescue. To your question of how long, in unresectable cases, what I can tell you, and I will have everyone else comment, is generally the philosophy has been you must give a drug holiday at 1.5 years.
Yeah.
Okay. Because the downsides and the side effects start rising and you need a drug holiday. In India, you correctly said affordability is a big issue. And we've had a strategy where 6 months you give monthly, then you give 2 monthly, and at the end of a year, you give 3 monthly, where you stagger, you increase the gap so that the effect and the efficacy remains the same. The cost goes down. Now, remember, this is not out of any planned prospective study, although we are going to do that in some form. But there are many centers in the world which have shown that increasing the gap may not reduce your efficacy too much, and very important for LMICs, where cost is a big factor. So now I would like to invite comments from Dr. Agarwal, Chetan, Mishil, Manit, Abhijit, to know how do they treat this differently in their practice and what has their experience been.
So I think, Prakash, you've summarized everything quite well. I think the principle is exactly the same. We get the tumor controlled in the first 6 months. Then you increase it to alternate month. I mean, you increase the interval of dosing. Then what we are doing is we half the dosage. Instead of 120, we are giving them 60 milligrams. And then again, make it 3 monthly and then put them on to 6 monthly. And maybe at around 2 years' time, if we feel the disease is stable, we do make an attempt to just withdraw it or just give them once a year. Now, I've had a couple of patients where the tumor has come back and we have to restart the denosumab. I don't know whether adding zoledronic acid is going to help us counter this problem in those cases where the tumor come back. But again, as Rohan has shown, all of us have had cases where the tumor does not come back. And for some reason, we know that it doesn't, the denosumab doesn't act on the neoplastic component, but the tumor somehow has remained silent even after withdrawal of the denosumab. There are a lot of other things which probably work in controlling that tumor, and that's probably at play. But I think it is very important to be cognizant of the fact that we are not talking of treatment for life. Somewhere we will have to withdraw the drug, otherwise we have to face the side effects, which can be at times worse than the disease of that.
And one important point which I missed, which Dr. Agarwal alluded to, is we published my colleagues. I think Prateek was also a part on that paper. Dr. Puri, Ashish. We published a big series of patients where, because Dr. Agarwal correctly mentioned that denosumab does not target the neoplastic component, and this was in an era where we did not have biosimilar denosumab. The original denosumab per dose used to be 35,000, which our patients couldn't afford. It was in that era where we use the best of both worlds, where we would combine denosumab with embolization with the hope that the embolization kills the tumor while denosumab gives us a symptomatic benefit. This was also the era where patients who didn't afford denosumab got zoledronic acid because it was cheaper along with embolization. Now, that data showed that even when you use embolization, our control rate improves much better, even with just 6 months. But despite all of this, 40 to 50% of them later on in their disease careers will relapse, right? And that is when, like MGA mentioned, we need to re-challenge them with denosumab. That problem is a little lesser now because biosimilars are available, which has reduced the cost by almost 50% and has made it more affordable. And by increasing the frequency or the gap between the doses, it has helped more patients gain access. Abhijit, did you have a point to make?
So, in unresectables or where the morbidity is more, like sacrum, whole sacrectomy, or pelvis, or bones like talus or spine, where the surgical morbidity is high, we are trying to combine both the things, denosumab and zoledronic acid. So, give short dose of denosumab, 0, 7, 14, or 28. Stop it, then one dose of Zol after 6 months, then again repeat it. So trying to make a sandwich like thing, because there are, we have seen complications like pathological fractures, iatrogeny because of Zol or denosumab. But still, it's short experience, what we can say, of 5 years or 10 years, where we have follow-ups of sacrum cases, which were unresectable type of things, for around 7-8 years. Sandwich, Zol, denosumab, 6 months, increase the duration between two doses. Angioembolization, we are not having cath lab at our center. So there is a cardiac center nearby, but not that accessible. So we have more experience of Zol and denosumab. Angioembolization, limited experience what we have. But both combined, unresectable tumors, good outcomes. In talus also, few cases now we have that we need a 3D printed talus or we require arthrodesis. So these patients are of nearly 3-4 years follow-up now. So we are trying to prolong when the surgery should be done. That will be ultimate take-home message. Arthrodesis or 3D printed talus can be done anytime. It's nearly 4 years follow-up and patient is still doing well, walking well. Like fibromatosis, we can say. It is keeping the disease in control. So giant cell tumor can be kept in control with these two drugs. Sandwich-like thing can be tried.
Now, an important point which I forgot to mention, but sometimes we face it quite commonly. I'm sure all of us do, where we cannot use denosumab, right? Which is in kids and in pregnant women. And we know that in pregnancy, giant cell tumor tends to progress very rapidly because it has known hormonal associations, and it's a very tricky situation because denosumab is completely out. And we've had patients, I'm sure all of us have, when they are beyond the gestational age where an MTP is possible, and occasional patients where they do not want MTP. They want a pregnancy preserving option. So, which is where our hands are really tied because you can't use the two big drugs that are available to us. You're forced to resort to embolization, and even there, the patient has to go in DSA with radiation exposure, and it's a very tricky situation, right? Where it's a big no. And that is where all of us need to be aware of using a decent strategy, having a team in play on how do we deal today with pregnancy and giant cell tumor where denosumab is out, MTP is out, and oftentimes even embolization is out. Any comments from the panel? Dr. Agarwal, sir, would you want to lead and then we can have opinions?
Fortunately, we have been in an era where we didn't have denosumab. So we didn't know what is denosumab for the first 15 years of our practicing orthopedic oncology life. So I think we've all learned that you have ways and means of controlling the tumor, and we tend to be a little more aggressive on the GCT. The challenge comes is in a sacral or a spinal GCT, where surgery may not be an easy option in a person who's pregnant, in a lady who's pregnant. But anywhere in the limb, I think we tend to be a little more aggressive surgically and deal with it rather than waiting for the pregnancy to get over and then trying to deal with it. So denosumab is a aid. It is not essential. Let's understand that part. So not having denosumab doesn't mean you can't treat the GCT. So as long as we remember that, I think we will be able to get options. Where your hands are tied in the sacrum, where again the tumor as well as the fetus are fighting for the same space, and you can't use embolization also because of the radiation exposure. You can't use the drugs because of the dangers, obvious dangers with it. I think that is a tough situation, which I don't think there is any reasonable answer of how you're going to deal with that. So I think sometimes you have to just observe that patient, care for the symptoms, and just let the pregnancy go on till the time that the fetus can survive once delivered outside. It is safe for that, and then go ahead and deal with the tumor of that.
Well, we've had a wonderful session. I've been given a hint that our time is up. And now I want, and thank you everyone. Great cases. This has gone much better than we all expected. We've all learned a lot. I just want Dr. Michelle Parikh and Dr. Manish Agarwal to now give their closing comments and close this wonderful session. And thank you everyone for being a part.
Thank you.
Yeah, so I think I have spoken a lot. I think I'll let Michelle do the closing remarks.
So yes, sir, every case and every discussion that your inputs were there were the take-home message automatically. And with everybody's cases and the end discussions, the only message that I feel should go to the common or the general orthopedic surgeon is that follow the protocol, follow the algorithm that has been created. Tissue diagnosis is of most importance. Follow it up with a proper planning with multidisciplinary approach, a team that has to be formed. Like Dr. Prakash also said, somebody would do a good oncological clearance and somebody could help in a good reconstruction. Never shy away from taking help from your colleagues, peers, juniors, seniors, whatever it is. The patient's outcome is the most important thing that has to be kept in mind. The enigma of denosumab, well, it is always going to be short time whenever we discuss this topic. And luckily, I have been told that even the main conference of WIROC, our topic of discussion is going to be giant cell tumor. So I'm sure our audience will get more answers when they attend that. All that I can say now is thank you very much to all the faculty who have given this Sunday morning to us and shown or shared their experience with management of giant cell tumors that the general orthopedic surgeon will be able to take tips and tricks from and become better in his practice. Also, I would like to thank the Bombay Orthopedic Society for giving the orthopedic oncology community a good platform to show what should be done and how it can be done better for the patient. At the end, I would again ask if somebody from the BOS is present for the closing remarks for the main conference.
There are two more points which I want to make. I think a lot
Yes,
of thought now has to be given by every orthopedic surgeon, whether they would like to manage the giant cell tumor on their own or seek expert help. We've debated this once in the Delhi Orthopedic Association, and I think there is so much knowledge which has come out now with the medical legal implications that I think giant cell tumor has to be considered like a serious tumor, and I think you should leave the management to the experts wherever such facilities exist. And I think in a city like Bombay, where a lot of expertise exists, I think it is best that these are handled primarily by the experts so that they have less problems. We've seen that the outcomes are much better when handled in the expert hands compared to when they're handled by general orthopedic surgeons. And the second thing, which again, point which I'm going to stress, which Rohan Gala pointed out from that case is, I think biopsies is something which is still being ignored. I think it is not important just to do the biopsy. Doing the biopsy is important, but also getting the right opinion is extremely important, and time should not be lost in that. Again, in today's era, we do have experts available where you can immediately send the slides and get a second opinion without wasting time or relying on somebody who doesn't have the experience. So I think that is a service to our patient where we can get a quick diagnosis and then send them over to a expert center so that they don't have any mismanagement or delay and get the best possible outcome which is possible in giant cell tumors.
Wonderful. So I think that summarizes it well. Everyone's just a phone call away, and we need to seek help and focus on the best outcomes that we can give to our patients. Thank you so much, Michelle. I think we can now end the meeting.
Yes, sir. Yes, sir.